Okay, welcome everybody. Wednesday edition of Talkback underway, and we have a special guest. First of all, in the studio, Bob Seiden-Schwartz. Welcome, sir.
Good morning, Peter. Nick in Missoula.
You bet. Nick Christensen right over there, and producing our show, waiting to take your phone calls, in fact. And on the phone with us right now is Dr. Peter Margella, one of the most renowned pandemic experts in the world, and we are very privileged to have him back with us. So go ahead, Bob.
Dr. Margella, welcome back to Missoula.
Good morning, gentlemen.
Now, Dr. Margella, you actually called a little bit early to kind of prime the pump a little bit about some of the things you wanted to talk about. So let's just jump right in here. One of the things you're very concerned about is what you call the White House's federal COVID-19 national response plan. So what are your concerns about that?
So just a couple of precursor thoughts. We're about at C plus 83 or so point from the commencement of this outbreak, and we're seeing a very rapid epidemic curve, which tracks in a vertical fashion on a Cartesian plane, a simple XY axis, how fast the outbreak is moving. And I want to come back to that in a little bit. As of today, we have COVID-19 in 161 of 195 countries, states, and territories in the world, meaning we're right at the 86% saturation point. 6 out of the 7 continents have active COVID cases now. The only exclusion to that being Antarctica, which obviously doesn't have a population at risk to be of much concern about. So this has by far reached, by anybody's definition, extreme pandemic proportion. One could argue that it had reached that sometime back in January, but for any number of reasons, the WHO was holding off on making that declaration, not the least of those reasons being the potential impact that might have begun with the announcement. On Friday, the federal government released its first version of what's being referred to, and this name may change, the National COVID-19 Response Plan. It's not indicated who was the author of the plan or what agency it came out of, but I expect that it was led by the Department of Homeland Security in close collaboration with the U.S. Department of Health and Human Services and their sub-public health organization, the Centers for Disease Control and Prevention. Today is the first day that we're hearing any news about the plan because it was initially listed as FOIO, or for official use only, which is not necessarily classified, but it doesn't offer wide-range distribution at first outside the government. The two biggest concerns I have about the plan, in the little bit of information that's been put out about it right now, is that it calls for the COVID-19 outbreak to last upwards of 18 months, which is quite a protracted period of time by any measure for an outbreak. And it also calls for an expectation that we're going to see 3 sequential waves or sine wave peaks of the outbreak, where we can expect morbidity and mortality, which I'll refer to as M&M data probably for the rest of the call, to subsequently go higher through at least the first 2 waves. And then the expectation is that we're going to see a resolving wave where we're starting to build some level of global herd immunity at the 3rd wave. These projections, the 18 months and the 3 waves, are built completely on what occurred during the 1918 and 1919 Spanish flu influenza epidemic, which had an attack rate of 50% of the population of the entire world, which was 1.8 billion people at the time, and was responsible for killing some 100 million people. The issues I have with this is that, one, first and foremost, this is COVID-19. It's a novel virus. The original protagonist virus was coronavirus, which we know we live with all the time, just like rhinoviruses. But this is a mutation, and we've never seen this type of virus before, and it is by no means, or it should be by no means, compared with influenza, which is a whole different animal that behaves in a completely different fashion. The second issue that I have is the time period and the waves. That 18-month period is exactly what happened with the 1918 and 1919 outbreak, as are the waves. And I've said before that the single inexorable truth about the spread of disease is that it leverages man's lines of transportation for its spread. And, of course, in that first early 20th century outbreak, those transportation modalities were rail and maritime platforms, respectively, and they moved the disease and the people who were sick very, very slowly. And that's not the case today. In fact, this is why I started off with this outbreak is moving very quickly. And the reason it's moving quickly is because it's being hypersped around the globe by the principal transportation modality of the day, which is the airline industry.
So, Dr. Marghella, a couple of questions. Wanted to go back to when you're talking about these outbreaks in these 18 months and waves, you with your background, try to help us understand what are they thinking when it's the WHO or the CDC or Homeland Security? What could be the thinking behind this? And when we hear this from you, and we're sitting here in the public, that sounds a little scary to think that this is going to be coming. It's going to be coming in several waves here. So give us some perspective. Is this something that, is out of the realm, or are they missing something? And if so, how do you start to think about this in a different fashion?
Or is it too late to fix it?
Well, first off, my first reaction to your question is, this seems to be at times typical of government response in dealing with a very heavy, burdensome unknown. That is, they try and fit a round peg into a square hole and expect that it can be jammed in to fit the framework of something that we have experience with before, instead of looking at the new science and the new data that's being presented and the new era that the disease is occurring in, and trying to fit it to the form of how things move, how disease is spread, and what we can expect to see from previous coronaviruses. You'll remember from previous discussions on this show, I mentioned that we'd seen two previous mutations of coronavirus before, which accounted for the SARS outbreak in 2002, and the Middle East Respiratory Syndrome COVID outbreak or coronavirus outbreak or MERS-CoV in 2012. In both cases, they had a fearsome start, and they had very high degrees of both morbidity and mortality. And on the MERS-CoV side, especially the case fatality ratio, which is the number of deaths caused by the disease matched against the number of people who have been reported to have been made ill by it. And in that case, it was 36%, which by any infectious disease concern is very, very high. So there's a lot of unknowns here, and I can only think that they're trying to box this in to something that can be manageable, at least thought of to be manageable, so that they can make adequate plans. But there's a danger here that I alluded to earlier with Peter, in that you're hearing right now this need to quote unquote flatten the curve, and the need to do this is to keep our healthcare system, for lack of a better word, from breaking. Flatten the curve refers to, and I can hope that the audience follows this, a simple XY axis, a Cartesian plane, and at the junction of the XY axis, you have the starting point of the outbreak.
Dr. Marghella, I'm so sorry. We're up against a commercial break, and I want to give you plenty of time to stretch out and explain this. So, pardon me for interrupting you, but as soon as we're back from the break, we'll continue with this because it's something we all want to hear and know. We'll be right back in a moment. Okay, we're back on Talkback. 721-1290 is our number. Bob Seidenschwartz here in the studio. Nick Christensen, I'm Peter Christian. Joining us on the phone, Dr. Peter Marghella, and interrupted you right in the middle of your explanation of what's going on with flattening the curve. So, Doctor, please continue.
So this may actually be the most important thing that I have to say today to the public audience that may be listening, and that is this notion of flattening the curve. I started to describe a simple XY axis or a Cartesian plane, and on that axis, I want you to go to the confluence of where the two meet, the X and the Y, and you could put a point there that represents the index case or cluster of this outbreak, and then what you take upwards, moving in a very rapid vertical climb, is this epidemic curve. And at some point, that curve will reach an apogee, and then it will begin to decline. And the apogee represents the peak of the global caseload or attack rate, And then once the decline begins, we start to see resolution of this outbreak or any other outbreak as the human species starts to develop some degree of global herd immunity against this particular circulating virus. If you would take another horizontal line and draw it probably halfway up the vertical axis on the plane, that represents the capitated and ultimately static level of healthcare resources to support this outbreak in the United States. And we count them generally in beds, and that number is roughly between 940,000 and 960,000 beds nationwide. The flatten the curve comment that everybody's hearing now, spoken very loudly and importantly, is the notion that we have to try and elongate the epidemic curve to keep it underneath that period or point where if we exceed that capitated amount and static amount of healthcare resources, we end up crushing the healthcare infrastructure of the United States because we can't accommodate the surge. And that's the other important term that you're hearing. Important people, important voices like Dr. Anthony Fauci out of the National Institutes of Allergy and Infectious Disease saying is becoming the most important thing we have to focus on. And how we do that? Well, we do that by separating very distinctly the two types of sets of symptoms that we have associated with COVID-19. On the mild side, you have people who will experience the same types of symptoms that they have when they get a common cold or a very mild case of influenza. Runny nose, scratchy throat, a light dry cough, possibly very low fever, and a general feeling of malaise where you just don't feel that good. You want to stay home and eat chicken soup, which, by the way, has clinical use in treating colds and flu. The other set of symptoms are the more serious ones, and these are the symptoms that will end up causing the highest number of deaths if either left untreated or we can't get them the resources that they need, particularly ventilators. And that's high fever above 101, feeling of tightness in the chest as if a metal band is being progressively tightened around your chest, making it more difficult to breathe, bloody sputum or sputum streaked with blood, and an intense fulminating expectoration that's a sign of pneumonia. In any of those cases, in the latter group, patients or people who are experiencing them should contact their physician and, at their direction, attempt to make a rush, literally, to an emergency room and hopefully an admission, assuming beds will remain available, because those are the people who are at most risk of succumbing to this disease.
And with that, we're going to take another break. We'll be right back. Wow, this is very compelling. I hope you're listening. Actually, I hope you're taking notes, and we'll start accepting calls if you'd like. 721-1290. I know Dr. Margella has a lot to go through, so I will be back with more with Dr. Peter Margella and Bob Seidenschwartz right after this. Okay, we're back on Talkback. 721-1290 is our number. Bob Seidenschwartz here in the studio. Nick Christensen. I'm Peter Christian. Dr. Peter Margella joining us on the phone. And Ed, I'm going to ask you to hold through the top of the hour because we have to finish this particular segment before we go on. So go ahead, please.
Dr. Margella,
Peter, go ahead. Yeah, Rob, let me just go ahead and finish the point I was making because it probably is the most exquisite point of the show. Individual citizens and their families now have to become active participants in protecting the nation's most important critical infrastructure and key resource sector in this scenario, which is the healthcare sector. And individual citizens and their families can do this by observing strictly what I just described. That is, if you have the lesser symptoms, call your doctor. The doctor will likely direct you where to go to get a COVID-19 test. That's important because in aggregate, we need to know the numbers that have affected this country and the world with this disease. And the only way we're going to get those numbers is if we collect it through the testing process. But by all means, resist going to the hospital if you have those lesser symptoms, even if emotion and fear is driving your concern to put you at that hospital space, because we all have to become active participants in protecting that infrastructure, not only for this COVID-19 victims that are going to be the sickest from this pandemic, but also everybody else who's going through severe and critical illness, including cancer patients, people with severe cardiac disease, pulmonary disease, the whole gamut of the types of patients that get people put in hospital beds in the first place. And it's really going to be up to us. And the phrase that Dr. Fauci is using is flatten the curve, protect the infrastructure. And I can't emphasize how important this is as we move forward in this pandemic.
So Dr. Margella, what right now we have just a brief minute here. What do you want to tell the community here in Missoula? We've got a very good, health preparation organization that's working very hard. But as citizens, what do you want to message to us in terms of this is a time to step up, and how do we step up beyond what is being described in terms of public proclamations?
In 1 minute.
Yeah.
So it's very simple. There's an axiom in disaster management and the emergency sciences that leadership in a disaster is always local. So my hope at the end of this discussion today is to put some real, true, paint a true picture of what's really going on and help local, the planning community and the healthcare community and the public health community who all has to work together in an effort to fight the highest impact of this event. A real means for moving forward in a way that's going to work for the listening community at the local level.
Okay, and with that, we are going to take a quick break. Ed, if you don't mind, I apologize. We're going to have to ask you to hold through the top of the hour. I know you have an important question. We have two other lines open. It's 721-1290. Of course, joining us on the phone, Dr. Peter Margella, and he's one of the world's foremost pandemic experts. This is not his first time with us, and so we deeply appreciate his being willing to share his very, very valuable time. I know he's highly sought after. We appreciate him being on the radio with us here on KGVO in Missoula. We will be right back after the top of the hour news. Keep it here. Yeah, we are back on Talkback, and I'm Peter Christian. Nick Christensen right over there, and joining us on the phone is Dr. Peter Margella. Doctor, I asked Ed to stay all the way through the break. So, Ed, if you don't mind, what is your question for Dr. Margella?
Okay, last night I was talking with my wife about these curves, and I just sketched them out. And I was wondering if flattening the curve could squish it out in time. Maybe the same number of people are affected, but over a longer period of time, and that's good because it would be within our care capacity. But is that a mathematical analysis that just can't be done because we don't know this bugger?
Well, good question, Ed. And actually, there's a couple of statements or questions within that. Epidemiologists and infectious disease people are married at the hip to numbers. Numbers are indicators of where a disease event is going in terms of its progression. Ideally, we'd love to flatten the curve by drawing it out. And one of the ways that at least Dr. Fauci at NIAID wants to do this is by reducing the number of case presentations at our hospitals. The concern is that we're going to see a storm surge, or some people are using the term tsunami surge, which will cause the healthcare infrastructure, as I previously mentioned.
Dr. Margella, are you visiting us on a cell phone, or are you on a landline?
I'm on a cell phone. I'm on.
Yeah, because you're starting to break up a little bit.
Okay, I'll sit a little closer to the phone. We live by the numbers. The numbers right now are showing it may be difficult for us to flatten that curve in hopes of preserving our healthcare infrastructure, and hence our emphasis now on trying to communicate to the population that they have to be active teaming participants in protecting this infrastructure, because it is so vital to the resilience and well-being of our communities.
So, Dr. Margella, when you're talking about we ended the conversation before the break about the most effective way to deal with this is in your local communities. So please tell us here in Missoula and Montana, which at the moment we have a few cases. I think people feel somewhat fortunate that we're in Montana and not in some of the big urban areas. And maybe I'm wrong about that, but what do you want to say to my fellow Montanans and Missoulians about really where we need to even step up, possibly more than we have already?
So I used to work for a four-star Navy admiral named Dennis Blair, who became the director of national intelligence. And Admiral Blair used to frequently tell us, as his planning staff, that we always had to plan to the worst case scenario, because if we did, we can accommodate any lesser contingency. In a pandemic, you really see two events occur. One is the global spread, and then second is the roots in the community. And I make it a habit of not trying to blow sunshine at anybody. Dr. Fauci, the most credible voice in the nation right now relative to this event, tells us that we should prepare based on the expectations, and I'm quoting him, that it's going to get much, much worse. That means that we as communities, where really the rubber will meet the road in terms of how we deal with this, how our healthcare professionals are dealing with it, how our public health professionals plan for it and plan to help the healthcare community as the delivery resource, and then how your emergency management personnel in the community and public safety organizations help to contribute to keeping the community stable and ultimately resilient. So I would say that we have to buy in at every community level, even in communities as less demographically concentrated as Missoula and Montana is, that there is an expectation that as this progresses, it could get worse. And now is the time to take the measures to prepare.
Okay.
One of the axioms.
Doctor, your phone is really breaking up. What we'd like to do is take a commercial break, and if you wouldn't mind calling us back, just hang up and call us back, and we'll see if that'll help the problem, because you are breaking up quite a bit, and we really want to get every word. It's all very, very precious. So we're going to ask you to just go ahead and we're just going to hang up right now, and if you wouldn't mind calling us back, Doctor, that would be great. We'll be right back after this quick time out. Dr. Peter Marghella will join us in a moment. All right. We're back on Talkback. 721-1290 is the number. Go ahead, Bob.
That's a very appropriate song, Peter.
Yeah. Dancing in the dark.
Dancing in the dark, it implies that I can dance, but do I know where that wall is?
Yeah, exactly.
I'm going to be bumping into a lot of things.
You bet. Dr. Peter Marghella back with us on the phone. We hope we have a better connection this time. And so now you and Dr. Marghella, we also have Brenda and Harry both waiting to visit. So go ahead.
Yeah, I just want to continue along the same course here, Dr. Marghella, in terms of we were discussing community-wise, and you were referencing who you had previously worked for, and I wanted you to be able to talk to the community and say what more, with what we already have is a very robust, a system here, what more do we need to do personally that really is asking us as Montanans to step up? Because we can do this, and this is part of the nature of living here that makes this place very special.
So I would actually ask people, especially community leaders, to copy down the list of the 7 functional areas that I believe need the most emphasis and effort dedicated towards them. We did 4 cycles of planning at the national level for emerging asymmetrical threats, largely in the post-9/11 era. And those were the National Smallpox Plan, which was written against the highest end of bioterrorism threat, the Catastrophic Incident Response Plan, which was written for domestic nuclear terrorism, and then 2 phases of federal plans to respond to pandemic influenza, which were done in 2005 and 2009, respectively. Out of that planning work, out of those planning evolutions, we came up with 7 areas that came to be known as the 7 pillars of catastrophic casualty response that, at a minimum, need to be the most focused upon issues in medical and public health-centric response events, which this, of course, eminently qualifies. And those 7 issues are surge capacity planning for healthcare organizations, patient movement and transportation, medical logistics and supply, mass fatality management, psychosocial support to affected populations, managing special needs populations, and managing the public health message. I would argue that there may be one other very important functional area that you could add to that, and that is the application of a useful degradation of the standard of care in national or global emergencies.
Okay. Let's.
So, if we get a minute, I'd like to explain why each of those are important and how they're actually confluent and work.
Doctor, may I ask you a question first? What mode are you using right now? Are you talking through a speakerphone, or are you?
No, I'm on a microphone on an earpiece. Would you like me to just use the phone?
Yes, please. Yes, please. We were it wasn't clear. Thank you. Okay, so please go ahead and go through each of those and tell us the particulars.
I just go through each of those and tell us the particulars.
Much better. Go ahead.
Okay. The surge capacity planning, as I've already alluded to, is probably your number one issue. You're going to have a very big expansion of the number of people who will be required to be treated within some type of either hospital or surge expansion platform that you might accommodate in your community. The planning factor that we're using right now comes out of flu planning, admittedly, but we're saying that one of the means to accommodate for surge is to count up the entire number of beds that are available to you as a city or county or whatever your functional area of responsibility is, and then multiply that by 400% for surge requirements. Now, obviously, that leads people to say, well, where am I going to get that? My hospitals are brick and mortar, and unless I, suddenly get a bolus of money to expand them as physical facilities, we'll never be able to do that. And you're right. So the alternative is to look at locations that can be built out as surge platforms outside of the hospitals. Some of the areas that we've talked about in the past are field houses and gymnasia for colleges and universities, schools, malls, hotels that can be taken over by local government under Emergency Powers Act, either at the Stafford Act level of the nation, a state emergency declaration, or a local declaration. And any of these facilities can have as little a capacity as a cot that could be fielded into them, where you can then stream patients to provide some type of nursing support at the direction of a higher credentialed medical person, who then becomes a force multiplier to the community in that he or she can direct the care through non-traditional assets like EMTs, religious organizations as volunteers, or even family members or surviving members who have gotten COVID and recovered from it. This is one of the models from 18 and 19 that proved very useful. I would argue that the other two that really require an intense concentration at this point is, or maybe three. One, we have to get people to understand that we are going to switch from a patient to provider model of the individual, which is the normal way we have a standard of care during quote-unquote peacetime. And in a disaster scenario, that paradigm changes from the individual outcome to population-based outcomes. And the hard thing for people to accept is that, one, the standard of care is going to be lower than what you're used to getting in the first place. And two, we're going to have to, especially at the worst point of this outbreak, rely heavily on the principles of triage, which are not in ultimate to save as many lives as possible, but it's to do the greatest amount of good for the greatest number of people, working under the presumption that ultimately the resources, and when I say resources, I'm talking equipment, supplies, personnel, especially ventilators in this case, are capitated, static, and will be exhausted. So we want to prevent that from happening. The other thing that I think is urgent is that we have to make a real effort to identify those special needs populations within our community. Years ago, when we started talking about this phrase, it was simply pediatric and geriatric populations that might require extra care because they couldn't accommodate themselves. But now we have a whole, broadened subset to include the homeless, to include people with mental health issues, to include people who have alcohol and drug issues, to include prisoners in our community, which represent a special population at risk because they are jammed together in a close facility. And if we see an outbreak occur, it's going to be a brush fire event within the prison system that can be avoided if we make the plans now. One of my admonitions to people is look at your own block, look at your own neighborhood, and find out who is going to need the help that they can't get themselves, whether that's an elderly person with coexisting morbidities that put them more at risk of this disease in the first place, or just because those people find it the hardest to access medical care and support in times of need as a matter of routine, given their age and infirmities. And make sure that you, as a healthy person, are trying to do what you can, either to help them directly or to identify them to medical and public health authorities as people who require special attention as this disaster worsens. The last thing I'll mention is, two things. One is medical logistics and supply, and that's a simple one because you hear in the news right now that we used to receive a lot of medical equipment and supplies, including pharmacy and drug items from China, and some of that supply, for obvious reasons, has dried up. But the other issue here, logistically, that's becoming a big concern is ventilators. Ventilators, for the most acute patients, are going to be the only way that they can survive the pneumonia that COVID-19 will present. They'll require mechanical ventilation to get them through the illness, and there simply aren't enough. There are manufacturers that are making portable devices right now, and I would admonish the healthcare community and the logistics communities that support them to look into where they might be able to get some to build out the available stock. The last thing is something that people just don't want to talk about, and that's the mass fatality management mission, which Jan Barry, in his book about the 1918 and 1919 pandemic, offers as one of the most important lessons learned, because they failed across the board in the United States to adequately prepare for having large numbers of deceased people. Now, these don't represent a public health threat in and of themselves. They don't have vectors that jump off of them and continue to spread disease, but they do represent an administrative burden, a family burden in terms of the settlement of estates and wills, and most importantly, there's kind of two most importantly, it's the religious rituals that people desire to have adjudicated for their family members who have deceased. And then third, they represent fourth, they represent a big public health concern in terms of what the psychosocial impact can be against the surviving populations in seeing lots of dead bodies that couldn't be accommodated for just because we didn't plan for this mission and an expectation that this could occur.
All right.
And with this pandemic, it could occur.
We are up against a break. Brenda and Len are both waiting very patiently to visit with you. We also have a Facebook question. We're going to come right back with Dr. Peter Margella. We've solved the phone problem. It's loud and clear. We're going to come right back with more of Talkback right after this. Okay. We are back on Talkback. 721-1290 is our number. Bob Seiden-Schwartz, kind enough to join us here this morning. And, of course, Nick Christensen there taking your phone calls, taking a lot of them. As a matter of fact, Dr. Margella is officially a Talkback all-star because he's filled up the phone lines. So let's get to Brenda. Brenda, you've been waiting the longest. Thank you for your patience. Go ahead. Hello, Brenda.
Oh, hi. Can you hear me?
Yes, ma'am. Please go ahead.
Just given the discussion, it sounds like every single person is going to get this virus sooner or later. Flattening the curve kind of takes it out in time, but it also extends the number of people. And from what I've seen on the Internet, which is not the greatest source, is that pretty much everybody is going to get it eventually. Is that something to pretty much count on?
Okay. Thanks, Brenda. She's asking, is everybody going to get this eventually, Doctor?
The answer is we don't know, and I'll come back to what we always say when we start off talking about COVID-19 or any newly emerging disease that we've never seen before, and that is we don't know a lot about it. We measure in the post-event period what is called the global attack rate, and that is a rate against the global population in the case of a pandemic that might be exposed to this disease. We do know right now that the morbidity numbers are climbing very fast. They've kind of made their way around the world in one of the most rapid successions that I've already pointed to, the fact that the global air industry has been facilitating. But it's virtually impossible for me to answer your question, Brenda, because we are not at the end of this, and we really haven't had the chance to crunch the numbers and can say definitively that this will be something that affects every single human being in the world in terms of illness. But what people are saying that I believe are in the know is like Spanish flu, almost nobody will have had this not touch their lives in some shape or form. Whether that's illness, family member, somebody in your community, we'll all feel this at some point.
Okay, let's get another call in. Len, you are on with Dr. Margella. Go ahead.
I just got a comment on what he was talking about areas where hospital beds and stuff could be set up. Right now, we're paying thousands of dollars for school buildings that are sitting there empty. The same way, the library, we're paying for that. We're paying for playgrounds and all kinds of stuff. When something like this comes along, what good is it? You can't use it. And if they want to set up stuff like in a school, you could have a storage area built where you had medical equipment and you had medical supplies, and you would have to have somebody that maintained that stuff to make sure it was good, but it could be done. But it isn't going to be the individual person that does it. That's where your government comes in. And I know everybody don't like to talk about having more government, but the government has to step up, and they have to make sure that some of this is done. That's what they're there for.
All right, Len.
And the other part of this is on the kids that aren't going to school right now. Years ago, when the Missouri River flooded, we got out of school 2 weeks before Easter and never went back. It didn't kill us.
All right, thanks, Len. Go ahead, Dr. Margella.
Well, Len makes some really good points. It sounds like there's already, a degree of saturation of available locations of opportunity to field surge capacity to. I would add to what Len said, and he makes good points, and I'll come back to the government thing in a second, that what's vital is that in those facilities, you have to have access to potable water, you have to have adequate sanitation and toilets to support whatever size of the population you put in there, and it's mandatory that you have working HVAC to maintain a comfortable ambient environment, because as shown in Puerto Rico and Katrina, especially in heat, the ambient conditions can degrade a patient's condition rapidly in a negative manner. As far as government stepping in, he's right. But I'll point out that, and I said this before on this show, most of the federal partner agencies, less the Department of Defense, have no control of forces. That's a military term. That means that organizations like FEMA and DHS and Health and Human Services do not have, large numbers of trained personnel who can come out and help. There is the military, as the Title 10 assets, the active duty force, that might be used under control of the U.S. Northern Command, but I would say a more ready resource that is at the ready go, if you will, from the Missouri governor or Montana governor, is your Guard and Reserve forces as Title 32 assets, who, unfortunately, there's not a lot of depth in the Guard and Reserve on the medical side, at least not in the Guard, but they do represent a large number of people who can help at the direction of competent medical and public health authorities support the affected population.
And with that, we're up against a break. And just want you to know, just got word from the governor's office and the state health department that there are 2 more cases in Gallatin County, both young men in their 20s with COVID-19. So we're going to come right back. I think that makes either 8 or 10 for Montana now. So we're going to come right back. Joe and Emmett are both waiting to visit with you. We have one line open. Dr. Peter Margella joining us on the phone. We'll be back. Okay, we're back on Talkback. 721-1290 is our number. Nick Christensen taking your phone calls. We do have a lot of them. Bob Seidenschwartz here in the studio. Dr. Peter Margella joining us on the phone. One very quick question before we go to Joe, Emmett, and Dave. Dr. Margella, I've invited our City County Health Department folks to listen into the show, but they're obviously pretty busy right now. So if you were to give advice, just general advice, to a city of 70,000 and the health department here, what would it be to help them try to manage this the best way that they can?
First off, be absolutely forward-leaning. You're behind the power curve of this event because you have lost the pre-event deliberate planning phase, where you could have addressed most of the things that could have been put in place the minute that indications and warning of the outbreak were going to occur. So there has to be an absolute, full acceptance that this is an emergency of large scale in your own backyard, and nobody's going to get a buy from this at all, because the acceptance is that this has potential universal impact in the human species. With that said, I would say take the 7 or 8 pillars of catastrophic casualty care that have been enumerated through other national planning initiatives to address medical and public health-centric response and plan around them accordingly, because you will enhance your posture of preparedness by making sure that those areas have had some form of addressal, even if they're not maximized, given the time, the fact that you're moving towards them as time pulls out and the caseload grows, you'll be able to better accommodate your supported population.
Excellent. All right, let's get Joe on the line. Joe, thank you for holding. You're on with Dr. Margella. Go ahead.
Thank you. I've heard a theory that the reason the flu subsides in the spring is because in the winter air is dry. So when you cough, the water particles in your breath can travel far distances and stay suspended in the air, and that in the spring the air is more humid, and your cough would run into these particles would run into other particles in the air and drop them to the ground. Now, I don't know if that's true, but if it is true, could there be some benefit in humidifying the air in, say, a hospital or in a grocery store or a pharmacy?
Thanks,
yeah,
Joe.
So let me give you a more accurate representation, and you actually bring up an enormously important point. The first point is when you start talking about changes in seasonal conditions, mainly temperature, those may only have impact or application against normal seasonal influenza. They do not have any application or impact on pandemic strains of influenza. And here's the most important point. This is not influenza. This is a mutation of a coronavirus that's undergone an antigenic reassortment and has now become more pathogenic and virulent in the human species, and hence the pandemic. We have no expectation that as we go into the warmer months, this is going to change. The only conditional elements that could apply is that there's a recent, as in last week, publication by the New England Journal of Medicine that showed that coronavirus can maintain active virility and motility indoors on smooth surfaces for up to 3 to 5 days, and that's contributed to, in terms of its persistence, the fact that we manage ambient conditions indoors, meaning it's somewhere between 65 and 72 degrees, so the virus will stay around for a while. Outdoors, we know that viruses as proteins, when exposed to direct sunlight and high levels of heat, they degrade much quicker outdoors, but the actual time is the jury's still out on that because of studies that are ongoing. But the important takeaway from these points is don't expect a change seasonally. Please don't compare this to flu. It's an entirely different animal. It's like comparing apples and porcupines. And we can't apply the rules and paradigms of flu, whether seasonal or pandemic types, to what's going to happen with COVID.
Okay, and with that, let's get another call in. Emmett, you're on with Dr. Margella. Go ahead.
Well, I have a couple of questions, and Doc, you just answered pretty much the second one, but the first one is, as far as I've been sick before with many things, and I've even was sick with the flu a couple of years ago during the Holy Week, but Tamiflu worked. I know there's technically no cure for this, but if I had this, couldn't I get some Tamiflu? I mean, it wouldn't hurt anything.
No.
And second of all, as far as this being a new virus, hasn't the human race has always seen new viruses? I know technically now that this is not your average flu or your average cold. That's pretty, comparing porcupines to bananas. That's fascinating. But we've had colds and flus and new viruses that the human race have never seen. I've seen more than my share because I've been sick on pretty much a deathbed many times.
Real quick, Emmett. We got.
Yes. Why in the heck are we being asked to shelter in place with this one and all these precautions, like the bars being shut down?
Okay.
In any other season, we've never seen this before.
All right, thank you. Go ahead, Dr. Margella.
I've got enough to answer. First off, this question. Again, back to novel virus. We do not have any medicine that can treat this relative to the symptoms that you will have, other than to provide you relative palliative care for minor symptoms. That is, if you feel uncomfortable, you have a headache, you feel body aches and malaise, Motrin or Tylenol will work. Chicken soup will work. Keep yourself hydrated. But oseltamivir, as Tamiflu, and the other antivirals that have shown some efficacy for pandemic strains of influenza primarily have shown to have zero efficacy against COVID-19. The other point to make is that we have no vaccine yet, and a viable vaccine at best estimates is 1 year to 18 months away. But I'm not trying to be a pessimist. I'll point out that SARS occurred 22 years ago, and MERS-CoV occurred in the Middle East, which has a preponderance of wealth that might have been applied to a vaccine characterization and development. And for both of those mutations of the coronavirus, we still have no vaccine.
Peter, I'm sorry, Dr. Margella. You're saying that there's not going to be a vaccine in all likelihood, but do you think that there could be some medicines that somewhat kind of mitigate the effects of the virus?
I didn't say that there's not going to be a vaccine. I said right now what our government tells us and what Dr. Fauci tells us is that in best case, a vaccine for COVID-19 is a year to 18 months away. I do know that they have started some very rapidly developed clinical trials against the primary characterization of this disease. But, of course, with any virus, we worry about a subsequent reassortment or mutation that worsens the virus in terms of its ability to impact human beings. And any virus or any vaccine that's developed in the earliest stages proves to show little or no efficacy. And they are presently, as of yesterday, looking at, I think, 7 different types of drugs that may be efficacious against COVID-19. But so far to date, we have no means to treat the symptomology of this disease other than life-sustaining measures when we have worst-case scenarios such as ventilatory support.
Okay, and with that, we're going to take another break. Dave is waiting very patiently on the line, and this is great information. I know it's a little scary, but the truth is important. That's what we're here to try to deliver to you folks. And if you have a question or comment, our number is 721-1290 or 1-800-568-5309. Or if you'd like, if you're at work and you can't get to the phone, you can send a message to our Facebook page, and Nick will pass it along to Dr. Margella. We'll be right back with more of Talk Back right after this. Okay, we are back on Talkback. Dr. Peter Margella joining us on the phone. And, of course, Bob Seidenschwartz here in the studio, and Nick Christensen taking your phone calls, of which we have all of our lines full, which is great. So let's get right to it. Dave, good morning. You're on with Dr. Margella.
Yeah, good morning. Yeah, I've read that the virus is mutating as it transfers from person to person, but I've also heard that South Korea is doing a pretty good job of beating down the virus. Now, have you heard anything about that?
Hey, thanks, Dave.
I've heard. First off, in terms of your comment, the virus is mutating. This is the business of viruses. They mutate constantly. They have almost a single mission in their existence, and that's to leverage their host population to the greatest advantage of the virus, not the host. So these things, any viruses, are constantly doing something called antigenic reassortment, where we see changes in the RNA of the virus moving around and mutating to do exactly what I just described. So that's an expectation we have to have about this. And there's 2 theories, by the way. One is that this is an antigenic reassortment that is the third antigenic reassortment of coronavirus, the first 2 being SARS and MERS. And now this is just the worst one because it's a natural progression towards a better hold in humans. The other is that this particular strain has been an existing strain of the coronavirus family, as have SARS and MERS, that have simply laid dormant in the zoonotic population that they first occupied, and we think it's back. And that when the opportunity was right, it made the special jump into humans, and now we have this outbreak. As far as South Korea, put their arms around this fast, and while they have nothing better than us in terms of antiviral drugs or an available vaccine, but they have leaned forward to embrace this as a major threat to their population and have addressed many of the concerns that I enumerated in those 7 or 8 pillars, probably leaps and bounds better than we have so far. And I think that in the end had to do with proximity to the index cluster and bloom that occurred in China.
Okay, let's get another call in. This is Joe. Joe, good morning. You're on with Dr. Margella. Go ahead.
Yeah, I just want to say that I would advise any county health department that there is a shortage of masks available to the public, and that could be a low-cost thing that they could do. And for Dr. Is it possible that this virus incubates in the sinuses, or is it incubating in the lungs directly? Is it possible to rinse the sinuses?
Okay. No, it goes right into the lungs. That's where this thing, has its. I used the term bloom a couple of times, but in the human physiology, that's where it roots and blooms, and then how it affects the lungs has a lot to do with the person's pre-existing health and other comorbidities. I want to make a comment about the masks because Joe is right in saying it's one of the areas of important resource that we're seeing a big growing shortage. And remember, too, by the way, that China is one of the biggest producers of surgical masks and N95 respirators, which offer a higher level of protection. And we're seeing global shortages, and it's impacting our healthcare system. Because remember, we still have people who have to go into, have serious operations that are life-saving or life-sustaining, and patients, who have tuberculosis and have other, conditions that mandate personal protective equipment when treating them. Masks are only, and I'm talking strictly surgical masks, are only utilitarian for people who are sick and may be expressing droplets through sneezing and coughing. They offer almost no protection for people who have not yet been exposed to the disease because the droplets are heavy, and in surgical masks, they are able to permeate the material or get around the sides and pieces of the mask that are not directly conformed to your face. That's why N95s are working better, because you have to be fit tested for those types of masks, but it's very difficult, if not impossible, to get those right now. So my admonition is preserve what masks are needed most, for the healthcare community by not using the mask unless you yourself are sick.
You got it. Okay, we have a quick caller question. Nick, go ahead.
Yeah, a caller wanted to know, is the virus more viable on moist surfaces? And if so, why are we still allowing takeout services?
It's not, there's no evidence that it's more viable on either moist surfaces. In fact, dry, smooth surfaces indoors are what's best propagating the virus in contact, other than being exposed to people who are either sick and have touched themselves or sneezed on you or coughed on you or touched you. And there is zero evidence that the virus is being spread in food.
All right, let's get. Well, I'll tell you what. We need to take our final break. It's just a 60-second timeout. We have Jason and Kevin still waiting to visit with you. This has been so great, you answering all these questions. We'll be right back with Dr. Peter Margella in 1 minute. Okay, we're getting ready to wrap things up, but Dr. Peter Margella joining us on the phone, and let's get the calls in that we can. Jason is up next. Jason, good morning. You're on with Dr. Margella. Go ahead.
Yeah, just 3 things that I've come across this morning. It seems like ibuprofen is like a no-go with this thing as far as if you have headaches and stuff, I guess it bonds with it. Aspirin is better. I've heard that South Korea and China are testing a malaria vaccine and seeing if that's being effective for this thing. And also I've heard that type A blood personalities are at higher risk than, and it seems like type O is at the opposite spectrum. They are the lowest risk. Well, if you can confirm or deny any of that.
Interesting. All right. So, Dr. Margella, go ahead.
As with a lot of things, all of this is speculation right now. The evidence base on this is still out. It requires a review of thousands and thousands, if not hundreds of thousands of cases before they can definitively say, yes, people with type A blood types are going to be more at risk of getting this disease. What you don't hear in that comment is that type A's might be more at risk of getting the disease, but type A's might conversely be the ones that are showing the best rates of survival. And as far as the other drugs, this is something that's getting viral and could easily fall into the disinformation zone. and that people are reaching for things, and malaria has nothing to do with coronavirus, which has nothing to do with flu, which has nothing to do with hepatitis, which has nothing to do with any other disease you could pick. So I would say urge caution. I would be very surprised if doctors are taking drugs that have shown either efficacy at the high end or no efficacy at all, and are trying it because it's a Hail Mary kind of thing. It's just not something that we do in science. So again, your sources of good information are the CDC, the WHO, and for the numbers alone, the Johns Hopkins University Center for Engineering, who has done a dashboard so that we could track this. And we only have a few minutes left. I'd like to maybe make a couple of positive comments, if we could.
Well, yeah, go ahead.
So first off, the good news about this, the good news can be taken out of this drama and dilemma of global concern. The healthiest populations in our global community, that is adults up to say 60 or 63 with no existing comorbidities like COPD and renal failure, and our transplant patients or immunocompromised or immunosuppressed. And by the way, smokers are not doing well with this because they're pre-candidates for COPD, and you become immunosuppressed every time you smoke a cigarette. Your level of immune function reduces about 20% every time you smoke a cigarette, and builds slightly back up until you smoke another cigarette and does it again. So this is not a habit that is showing good results, and it may be a reason why we're seeing such high mortality in places like Europe and China, which have much higher incidence of smoking. So if you're a smoker, stop, because you're putting yourself at more risk. But back to the point about who's surviving this. The adults who are otherwise healthy who get this, we're seeing a 96.5% total survivability rate and a return to previous health with no medical issues subsequent to the exposure and sickness. Similarly, in children, you're kind of perplexing the pediatric population because, or pediatric provider population, because they're showing a low incidence of the illness, maybe a bigger number of carriers, perhaps, but they're showing a relatively low incidence of the illness, and they're treating it when they get sick, just like other childhood illnesses like chickenpox. They get sick, they're sick for a couple of days, they have a quick resolution, and they're back on their feet and off to school. So the numbers that are showing, the worst case outcomes in terms of mortality are people who are sick and people who are old, and people who have a lot of conditions that kind of have put them in an much higher at-risk category. The other, point of goodness, if you will, at this point, is I'd ask you to look at the numbers in aggregate. And let's just take the United States. As of today, we have 6,496 cases in the U.S. It's called 6,500. And our population at the moment is right around 326 million. So if you would divide 6,500 by 326 million, you get a 0.00006 incident. I may have added an extra zero, but the point I'm trying to make is, in the big picture of things, the numbers, any epidemiologist would tell you, are statistically insignificant right now. That's not to say, and this is an important point of emphasis, that's not to say that this is a dangerous outbreak that is rapidly spreading, that may have a profound impact on the United States, our neighbors, and the rest of the countries of the world. And we really have to embrace preparedness and the ability to get through this by observing the recommendations and protocols, including social distancing, including, hygienics to beat the band, to avoiding touching your mouth, nose, and eyes, which are all transmission routes for this disease, to avoiding exposure from people who are showing active symptoms of any disease, but most importantly, expectorating, sneezing, or coughing loudly and harshly. That could be expressing hot virus. And if we do some of these things, if we kind of have the engine of our society come down a little bit for the moment and kind of back off and observe these social distancing protocols, I think we can get through this as best we can.
Now, Doctor, in the 2 minutes we have left, someone had said that the plasma of people who have recovered, could that be a possible a working solution to try to find a solution to this? If people have already.
Yes, there's a procedure called, I want to say it's something called ECMO or something, and the abbreviation, the terms of the abbreviation escape me at the moment, but there's been a procedure that's been used in the past where they take the plasma or blood of patients who have had the disease and ideally have survived the disease, and they use it to make transfusions in the sickened patients in hopes of basically delivering a bolus of antibodies that have been developed from the surviving person into the sick person. This is not a cheap procedure. It's not a non-time-consuming procedure. It may add to the difficulties of the healthcare community, and as I said earlier, we're definitely going to see a degradation in the standard of care, and it may be at some point when we start to see peak numbers that even if initiatives like this showed efficacy in enhancing survivability, it just literally may not be something we're able to do.
Doctor, we have less than a minute. Where can we read more of your work?
Oh, so I probably should have a website, but you can look up a lot of the articles I've written just by Googling my name. Probably the best to look for is a public health case study in a book that was called the 2009 and 10 influenza pandemic. When we make mistakes, don't miss the lessons.
Got it. All right, Doctor, you have been so gracious to give us this much time. Thank you very much, and please, we want to visit again when you're available.
Sounds good. Thank you, Peter, and thank you for having me.
You bet.
Take care.